This is the January 23rd, 2025 meeting of the Oregon Pain Management Commission. I'll call the meeting to order. We've had a couple, it looks like we do have quorum. We do have one commissioner having some technical issues that we're working behind the scenes to bring him onto the meeting, Dr. Pengelly. I guess we'll start with the roll call. I'll just start by which commissioner I see on my screen first. And remind all commissioners that if you want to speak, because I've got multiple screens open with different PDFs and web pages related to the commission's business today, if you put a little X in the chat, that'll be my signal that I'll be able to see that you want to speak. So Shinta, please, if you'd like to go ahead and introduce yourself.
Good morning. Good morning. My name is Shinta. I'm the pharmacy director for
I will
Association. I'm a pharmacist and currently working as a pharmacy director.
Thank you so much.
There was some feedback with your audio there. I don't know if anybody else heard it.
Yeah. Can you hear me better now? Hello? Okay. Yeah.
Much improved.
Sorry about that. I'm in the room with other colleagues. So yeah, my name is Shinta. I'm the pharmacy director for Native American Rehab Association. I have my background in Indian Health Service, and I'm a consumer officer for the United States Public Health Service. Thank you.
We might have you work to try and maybe manipulate your microphone a little bit better. It's very muted. Sorry. Yeah.
I wonder if it's using a different microphone because I was barely able to hear.
Okay.
Oh, really? I just have, my voice is very low.
Okay.
I apologize.
That sounded a little better. No worries.
Yeah. Sorry about that. Do I need to repeat?
Okay.
Okay.
I think we'll move on. Yeah. Russell, you're next on my screen.
I'm Russell Wimmer. I'm a physician associate practicing at a standalone clinic in Brownsville, Oregon. I do primary care and also do some management on addiction medicine and specialize in severe persistent mental illness.
Michelle?
Hello, good morning. My name is Michelle Maricos. I am a peer support specialist from Southern Oregon, specializing in chronic pain. I am a person living with chronic pain. Thank you.
And Christine?
Hi, I'm Christine Martin. I'm a pediatric anesthesiologist working at OHSU Dornbecker Children's Hospital in Portland, Oregon. And I'm the director of our inpatient pain management service at Dornbecker. Thank you.
And Chavala, is this your first meeting or am I mistaken? No? Oh, okay. My apologies. So please, yeah, introduce yourself.
Sure. My name is Havala Bates. I am
Havala.
a health coach and social worker. I'm also a person living with chronic pain, and I work for Adapt Integrative Health. Thank you.
Eve, you're next on my screen.
I'm Eve Klein. I'm a neurologist with fellowship training in interventional pain medicine and addiction medicine. And I'm currently the senior medical director at CODA.
Britta, good morning.
Hi, good morning. My name is Britta Gergel. I am a pediatric physical therapist working at Oregon Health and Science University in Portland, Oregon, with the Pediatric Comprehensive Pain Center, mainly outpatient.
Thank you. Terry?
Hi, Terry Manning, a naturopathic physician practicing in Lake Oswego. I do interventional orthobiologics. Yeah.
Okay, well, thank you, everybody. I'm Zachary Corbett. I'm the chairperson. I'm a licensed acupuncturist in Eugene, Oregon, working in a community health center and in private practice with a focus on chronic pain. So we'll move on to the first item on the agenda, be the staff report from Mark about new member recruitment and 2025 commissioner renewals and expirations.
Yes, good morning, everyone. I'm Mark Altnoff, and I am the staff of the Oregon
Pain Management Commission and Palliative Care Council. So we have wrapped up our recruiting and are in the midst of appointments of two new commissioners. I won't say anything more than that until we get the final approval on the appointments, which hopefully will be coming soon. But we're excited to have two new members to add to the commission. And then we had four commission members who will be terming out in terms of their first term. So have served their first 4-year term. Cody Trawick, Lena Dorfmeister, Dr. Suchkoki, and then Shinta. And so I've heard from 3 of those individuals. One is still we're still working with to see if they want to continue on. But 3 have decided to continue to move on. And so as soon as we get those approvals, we'll make those final and formal. So that's all I have in terms of the recruiting and ongoing appointment update. So we should be at about 17 for the May meeting, which would be great.
And Mark, sorry, the line's a little scratchy. What was the number of commissioners who will be leaving us?
So we don't have anybody formally leaving us at this time.
Oh, no formal resignation.
I just have
renewals. Okay.
One of the commissioners that is up for renewal is still communicating. So,
okay.
Yeah.
And I know we've got Scott Pengelly now on by phone.
I've managed to get here in video person.
Oh, you're on video. Great. Okay. Thank you, Scott. Did you want to briefly introduce yourself, Scott?
Good morning. I'm Scott Pengelly. I'm a pain psychologist in Eugene, Oregon. I wrestle with chronic pain. I was a 2-sport athlete for a long while, and I was in 2 wars in the Middle East. I've been doing this work for 48 years, especially working with folks with chronic pain.
Thank you. Okay. Well, the next section of the agenda is ideas for what you'd like to see the commission work on. I hope you all had a chance to think about that. And if not, I'd like to have a bit of a brainstorming session. We've had some other projects come up, like our recent work on the CDC guidelines. And this probably ties in a little bit with the website work that we're going to be doing. But does anybody want to get the ball rolling with some ideas of where they, what kind of projects they'd feel they'd like to see the commission embark upon? Okay. Oh, Michelle, please.
I think I brought this up last time too, and I'm going to bring it up again since you're asking about bringing pain commissions to other states in the U.S. There's 2 senators there's one senator in Montana and there's one senator in Illinois that would like to, talk to us about doing pain commissions in their states.
Yeah, a little bit, could you unpack that a little bit more?
That they're interested in bringing pain commissions to their states.
Well,
I don't have anything more to unpack.
Are they writing draft?
They're
bills?
both of them are doing work within their states about the pain and opioid crises. The senator from Montana, they're both women, and they are interested in talking to the pain commission and about what we do and about how to start a pain commission in Montana and Illinois.
So that could be a segment we could have at a later meeting. It sounds like then they'd be willing to come to a meeting of ours and talk with you.
Yes.
Okay.
And ask questions, and kind of, that's just an idea that they've come to me and asked if I would propose it to our commission.
Yeah,
They could also reach out to us as staff at any time. That might be a good first step.
Yes, I will do that. I will connect them in with you, Jason.
Yeah, Scott.
Montana's had a long history of their own pain society and have done good work integrating multidisciplinary care for people in Montana. Glad to hear.
Yeah. So yeah, just to let commissioners know, if there's ideas about like this to have an actual segment in a meeting, that Russell, Mark, Jason, and I meet pretty much every month to discuss agenda items. So the best way, if you have an agenda item, you want to invite a speaker or have some time to talk about a particular topic, is to send that to Mark, and we'll see how we can schedule it. Scott?
There are two I'd like us to be addressing. One is the line that Oregon Health Plan will permit care for, and so often the strategies that are recommended for pain patients are not supported by Medicaid, and they're plausible, well documented, science-based, evidence-based. And yet we're fairly limited working with Oregon Health Plan patients. The second is I'd like us to look further at, I'm shifting gears here, I'd like us to look further at regenerative medicine strategies such as prolotherapy, PNP, stem cell infusion therapy, and be able to address that with our broad community that we participate in.
Were you thinking some sort of research review, or?
So that it is, we're including it in our pain science discussions and recommending this for care for our patients.
Okay.
Yeah, I'd just like to address that first one and actually apologize to y'all. We should have brought this proactively. There are some changes coming to the Oregon Health Plan, and the prioritized list. Our federal partners in the last waiver renewal said that the prioritized list, which it was the first Medicaid waiver in the nation back in 1994 under the 1115 program, they said after 30 years, it is no longer a demonstration, and they want us to end that by the end of 2026. The result of that is that there will no longer be a funding line. The plan is, pending the Oregon legislature's action, that HERC, the Health Evidence Review Commission, which creates the prioritized list, will continue to exist, but it will change to a medical necessity review instead of prioritized list, which means there will be no funding line, no unfunded conditions, but there will still be, as there are with all health plans, some services that are and others that are not medically necessary, some that are and some that are not in the benefit package. For example, at the HERC meeting last week, a proposal was approved to add coverage for acupuncture for tension headaches, which has long been an unfunded condition. And there was also a proposal to add manipulative therapies, chiropractic and osteopathic manipulative therapies for cervicogenic headaches. So headaches that generate from the cervical spine. That will be brought back to our meeting on March 20th. We also discussed fibromyalgia and Ehlers-Danlos syndrome and related hypermobility syndromes, which I know are of interest to many of you. And there was a proposal to add coverage for Ehlers-Danlos syndrome using some criteria from 2017 that were developed in the international guideline and say, to encourage interdisciplinary care, and referencing Statement of Intent 5, I believe it is 5, which references your work with the pain module. So it does not add physical therapy per se, although it specifically says that physical therapy can be performed for the manifestations of the conditions. For example, if somebody has a sprain or a dislocation or some other outcome resulting from Ehlers-Danlos, that could be covered. What wasn't addressed was hypermobility spectrum disorder or some other related conditions that advocates have talked about. I think they're less generally accepted in the medical community. That will also be coming back to our March 20th meeting. And
Okay. Well, thank you, Jason. We want to just carry on the topic of
well,
projects for the.
I just wanted to invite people to
Oh, please.
watch our website and come to that meeting or offer public comment. We'll be publishing meeting materials next week. And with that, I'll let you back to your agenda. But
Thank you. Terry,
wanted to address that.
you were next to speak.
Well, Dr. Pengelly, go ahead and with the follow-up there, and then I'll jump.
Sure. Jason, you've done wonders for my self-esteem. I brought up the line, the support line with Oregon Health Plan, and poof, it disappeared. I'm feeling powerful and I'm bulletproof. Thank you.
Okay. Yeah, we want to steer it back to the agenda item. So we'll leave the priorities list for now. Thank you, though. Terry?
Yeah, I mean, I would echo what Dr. Pengelly was saying about access. I mean, our module is, and we all know, practicing on patients with persistent pain and such, that a multimodal approach is the best way, and not one thing works for everybody. And oftentimes, trying multiple modalities will to as best as we can, yet a lot of those modalities are not covered or out of pocket or very hard to access, whether it be by geographic or financially. So I think access is a big issue. And
if I may, like, how would you draw a line from there to something that the commission might do as an action?
Yeah, on our website. So perhaps we can have something on the commission's website about, for patients facing, about strategies to help them access this care, strategies on perhaps how to optimize their plans, maybe something like that, or things that other people have learned along the way to really kind of get access to more of the modalities at a less of a financial burden.
So patient information on the website.
Yeah. And then in that regard, I mean, I did send over several kind of versions of trying to really summarize new and emerging to try to get in this module. It just didn't get much traction, but perhaps the module is not the correct spot for it because it's a lot to cover in 1 hour. And so maybe that should be something that should be on the commission website. There's a lot of things. I mean, like when we're talking about the regenerative medicine type of kind of umbrella term, there's a lot going on, and it's both encouraging when done right, but there's, I think, a lot of potentially bad actors acting on the hype of the term. And so having a resource on the Pain Commission, maybe helping practitioners, but also the public, be able to identify legitimate versus potentially illegitimate regenerative medicine therapies, and just some guideline information about that. I'd be happy to help out with that. I think that'd be a good service for the commission to work on. I could lay out, I mean, I'm lecturing across the country on some of these things as it is, but I mean, I could lay out some of the things, but I just need some help on getting the ins and outs on the website.
Yeah, so start sending things to Mark, and as I say in our monthly meeting, we'll start doing a deep dive into your materials. So thank you. Yeah. Britta?
Yeah, I think the things that would be helpful, kind of stemming off of that, is just the patient self-care resources that's currently on the website is super thorough, and I love that. It's also like, if I was a patient and I opened that up, I'd be like, whoa, this is hard to read through. So maybe making the patient-facing materials a little bit more accessible from a health literacy perspective, as well as just like breaking it up into the different sections so they can choose what they're looking for. And then, of course, I always bring up pediatric things. So having some provider-facing and patient and family-facing materials for resources for pediatric chronic pain would be my 2 suggestions.
Yeah, thank you. Yeah, this is obviously going to overlap with the website discussion, but to have on our website, yeah, you should try a little heat and ice if you suddenly have your back hurting. I mean, it's a little bit, I think we could do better. Christine, please, you're next.
And yeah, kind of building off of what Terry brought up, but I think access for patients to be able to utilize the services that we're recommending for chronic pain management. And so thinking about as a commission, like, do we have an understanding of like what providers we have in our state that treat chronic pain? Do we have a sense of like which regional areas have the lowest access to some of these services? Are there ways that we can encourage providers to take on chronic pain patients and provide more resources for providers so they're willing to accept these patients? And are there ways that we can like advocate to the legislature or other larger bodies to kind of bring in or provide more opportunities for additional providers to provide these services?
Mm-hmm. Yeah, I think there was some discussion. It's probably pretty challenging to keep up-to-date lists of active providers. Do you have any of the commissioners at this time, any thoughts about what Dr. Martin just said about how we can maybe put some of these ideas into play? Any like example action items, what that might look like?
I know this is something that's of interest to the medical board as well. And on our website, we have information encouraging people to step in and help out when patients lose their access to somebody who's been prescribing opioids. So there might be opportunity to partner with the medical board around that as well. Not exactly certain what it looks like, but we are on board.
I've certainly talked to local prescribers that are still very concerned that, their best clinical judgment, they're not running a pill mill, they're being as responsible as possible, but dealing with a medically complex, severe presentation, that in that space of complexity, they fear for their some sort of action on their license. It's still very difficult, at least in the Eugene area. Scott?
Would there be a way to include on our webpage topics that Terry mentioned, that I've mentioned, Britta, Michelle's mentioned this morning, strategies that are being discussed or being addressed, that we're looking at these on the webpage? I think that would be helpful.
Oh, you mean to have on the page that this is what we're trying to do?
We're taking a look at it. We have a small box and we're not looking outside the box, and your interest, we're going to gaslight you. It doesn't exist. Well, that's the sort of criticism we're under, and we're saying, here's the scope of what we're looking at. Let's state it some way so it can be seen.
Yeah, I mean, in our website, there's the pain care toolbox. I think there was something about scripting that probably could be updated. I don't know if anybody's seen that PDF. So yeah, it looks like the website conversation and our special projects conversation has significant overlap here. Any other comments at the moment? Have people clicked through the website? I must admit I was rather cramming myself to get a sense of it all. Some of it looks a little bit out of date. I have a feeling there's probably some links that are old. And I think there could be more, like Britta said, some more focused targeting. I didn't find anything about pediatrics at all, actually. If you click on to, there was one of the what is this? The Pain Society's Pain Association's got a journal called The Chronicle. Looks like a magazine for patients, but I have not clicked through any of the editions of that yet to see if there's anything in the pediatric space. So, great. So. Jason, I guess you'll put that is that appropriate to put the date of the next meeting in the chat for the herd?
Yeah, I'll put the date and also our meetings page where you can watch for the meeting materials, because we are looking for written comment on those. That's really helpful because it gives our medical director a chance to research things before the meeting. So I'll put all those links in the chat. And feel free to follow up with me if any of you have questions after the meeting.
I might, just because we've got 1 minute, when you say medical necessity review, is that instituting quite an extensive prior authorization process then?
Well, prior authorization exists today for services in the funded region. For example, if your provider requests a discectomy, that'll be prior authorized, and HRC has criteria about when you could get that. But that will apply to other things, including things that today are below the funding line and wouldn't be covered. Like, again, acupuncture for tension headaches got added. Potentially some other services need to be looked at. And so that's something that those of you in this field could provide helpful information if you have expertise on the evidence or rationales, or just want to give feedback on the proposals. I know our medical director and our commission would really appreciate that. So I'll stick those links in the chat.
So it's 9:30. The next agenda item is the public comment section. Mark, how are we looking for that? Do we have anybody on deck?
Zachary, I'm not seeing the two individuals that signed up to provide public testimony signed in with their phone number or their name. I see a guest and I see a area code 503 ending in 342, but those aren't the numbers I have for the sign up. So you may have extra time, and they could possibly be looking to sign in 30 minutes prior to the second public comment session on the agenda here.
So I guess there's no process for us to establish who guest or the 342 number might be. I see.
Unless
I have to follow the rules here. Okay. Okay, well then let's move on early to our well, we have the next agenda item is the module update. But since we have this extra 10 minutes, is there I think I'd like to just ask, does anybody have another agenda item that they'd like to introduce? I'm willing to entertain. We've got some crossover between special projects and changes in HRC and our website. Anything else anybody feels like we should be tracking? Even just introduce a topic before moving on to the next agenda item? Not seeing anybody there. Okay. Yeah, just thought I'd ask. So, right, we've got the next agenda item. It's the status update of the module and lessons learned. So, information sharing and discussion.
Many lessons learned in the module. So first, the update. So we're close to the finish line on getting the module turned on. We obviously missed our deadline of January 1st. We've been working with our vendor OSU, and they've been very good at trying to deal with some internal issues that some of their staff have had some medical issues. So, but I'm crossing my fingers that we turn this on February 1st. And then in the next week, hopefully be able to send you all a final link that has the course that you can run through it and take a look at it. Obviously there won't be any edits at this point, but we have approval certification through the pharmacy board, through the nursing association, and still waiting on the medical association. So I'll be in contact with them. I am in contact with them daily, but hopefully that'll all come through here in the next week as well. And so there's the transition piece of turning this on and what we do with the old module and how to help people who are taking the course navigate, okay, I've taken the old course, or I'm coming back to finish the old course that I started in October, and where do I go, on the web page, and then, well, I'm taking the new course, and how do I navigate to that? So I think we've got some mock-ups for the web page that'll help folks do that. And Dr. Koki is joining us, and then I think there's also the transition of people that haven't finished or didn't get their certificate or lost their certificate. How do they contact who do they contact to get that? We have support from Mark Stevens, who is the consultant that developed in the IT side and manages the customer service for the old module. He's on through, I think, into June to help with customer support. And then we'll also have staff for Oregon State University that'll be helping us. We're going to put some language on the website also just about certificates, because that's the biggest customer service issue that we deal with in terms of people. You can't print one, or they can't, find it, or they lost it, or, some of that kind of stuff happens. Sorry. And then in terms of lessons learned, I think from a staff perspective, and Jason can certainly chime in as he sees fit here, I think we tried to do our best to manage a long lead time project, and there were some things we could have done up front and earlier in the process, and gotten out to you all to help mitigate some of that. Part of it was the delay in the contracting. That was just a huge issue for OHA, and our contracting didn't get done until late in the fall, and we had the project in the timeline to have that done last spring. So that was a big part of it. I'm sorry. Jason, anything else to add there? Sorry, my hound is barking in the background.
Yeah, I think we might move to the slides stage where we're actually developing content sooner, so you can get some more concrete feedback. We can tweak things earlier, so what you see is more like what you expect. We took the approach of trying to block times, and it just became difficult to match those, and we didn't have sufficient opportunity. So that's something I'd like to see us do earlier next time. And I'd like feedback from you all on that approach. Is that a good approach, or are there other things you would suggest we do different to improve the process from your perspective?
Okay. Yeah, the floor is open. Yeah, I think the challenge was designing content for a vehicle that we didn't know the parameters of. And my perception is that the relationship design process with this team is pretty straightforward, and chances are we'll just be using the same team next time. So we'll be a little bit more directly, if the commission's spending time voting on, hey, we think this should be in it and not that, but we like this, but not that, it's going to be a lot simpler generating the final product. Is that a correct perception, that we're most likely in 2 years we're going to be working with this same team?
Yeah, Zachary, that is the case, where there were some lessons to be learned once the contract was signed and we started actually having an opportunity to work with a vendor on what can they do. And there's a lot of details around what can you include in the learning management system, and then there's other things that have to be included outside of that in a different software for the testing and post-course evaluation, and can you link to resources in the module or in the learning management. Lots of details like that I assumed you could do based on just working in different software and creating other programs in my life, but they weren't able to do it in Articulate, for example. And so there'll be some things that will be on the other side of the lead time on from that perspective, because they'll be on board early. And then we've just gone through one iteration, and this is the first time the commission is fully engaged in a public meeting process to do this. I mean, historically, commission members had worked off to the side as subcommittees and things, and it was kind of they brought the finished product. And Michelle, I know you can see you shaking your head, you were part of that, and it was just like, it kind of, the commission then just approved it rather than getting their hands into the thick of the content. Michelle, do you have something to say there?
Yeah.
I do, and I want to commend Mark and your whole team and the media team for doing this process without those subcommittees, because I think that it traditionally in the past the subcommittees did roll a little bit faster in kind of getting content and getting things produced and done in the way that were more efficient. So I really want to thank you for that whole process. And I wanted to ask a question about, like, is there ideas about how the Payne commissioners ourselves can help more in this process?
Well, I think again that's going to be staff driven, so that you have the content to work with. Clearly, it was kind of a here's a general outline, and fill in the blank versus staff creating a bunch of content and saying, okay, edit all this in this section. And, that I think, as Jason said, we want to be more in that space where you're getting a slide, seeing the content and working with the details rather than coming up with it. I mean, that was kind of how this rolled out in my mind. Does that make sense? Okay.
Yeah, I had a couple points. I think I was a little concerned we were writing about professions who weren't actually on our commission, and that may happen again, depending on where we're at when we next review, osteopathic manipulation, chiropractic. Britta, we were without a PT for quite a while, and so I think just to plan ahead a little bit, if we're at the point of needing to design a section about a profession that's not represented, if we could have some outreach to the Oregon State Professional Association or one of the local training colleges, to see who might be able to provide, the information that we might be looking for. And the other question I have is, for the next iteration, any ideas how to limit how much AI generated text that we're using, or to attenuate that? I think the AI voice was fine. I personally didn't have a problem with that, but be great to begin to rely a little bit less on the text generation. And if anybody had ideas about that, or agree with me or disagree with me, I'd love to hear some feedback. Were people okay with the amount of AI generated content? Oh, okay. So I may be in the minority here. Scott.
I was not enthused listening to the monotone voice. The term we use all the time, prosody, emotional intonation, was lacking. So it was very difficult I'm exaggerating when I attempt to mimic the AI voice, but it lacked for emotional intonation and therefore importance that was carried in the voice of the AI generated.
Oh, okay. So, and just to be clear, there's kind of two situations we're using AI. One, like you mentioned, for the presentation, but we also used AI for generating content, actual copy and text, that the robot wrote the words that the robot read out loud. So there's sort of two spaces here using AI.
We were involved in reviewing that and prompting it. So if it came out reading wrong, that's good feedback. But part of that was the time frame, and that's part of the reason I'd like to front load it earlier. In addition, the vendor said we could do human voiceovers in the future, but again, given the timeline and the contracting delays, that just was not possible. Okay. And it makes it harder to edit if something would need to be changed later. So we'll need to balance that all.
Jason, what's the cost difference between having a voice actor versus the AI? Do we have an idea? Is it twice as expensive? Is it, 4 times as expensive for that specific portion of the budget?
Honestly, because of the time frame, we were just just wasn't an option, so we
Yeah.
didn't price
Yeah.
doing a voice actor, but I think
Okay.
it's certainly something we can explore.
Well, and
Yeah, so and I think that's completely reasonable. I mean, I have a different take on it, which is that when you look at how many different services, for better or worse, that we use, from automated customer service processes to Alexa, and hopefully I didn't activate that in 7 of your offices or homes. It's integrated everywhere. I think it's becoming a lot more commonplace that yes, the intonation's off and the inflection can be slightly off, but the content is still being read. And when you're taking into account your audience, which is predominantly medical providers and medical professionals, delivering a trauma-informed message without having the right emphasis to make it feel like it's an emotionally congruent message, I don't think that that's going to offend or hurt the feelings of the providers. They're going to understand and read it through a trauma-informed lens. So the AI is not losing its effect because the content is really the purpose. And in the future, I think it's reasonable to, if we really want to, go with a voice actor. But in my experience of doing projects with both options, voice actors are markedly more expensive, and it does affect the total budget and what you can accomplish because of it.
yeah, Russell, I'd add that we spent less than half of our budget, or the total budget that was for the previous module. So, you know, it was sort of $450K. We're less than 200 for this.
Oh, wow. Even with inflation, that's pretty good going.
So, I mean, there was significant cost savings. Now, I agree, there's, you know, pros and cons to the end result, but
I just wanted to check in briefly with Shinta. Shinta, you made a note your camera stopped working. Can you still hear the meeting? Just give us a thumbs up or something in the text. Oh,
Yeah,
you're
I'm
off.
still here.
Okay, marvelous. Okay. That's
you.
fine. Just wanted to check your audio was working.
Mhm.
I have a compliment about the module from a very busy interventional pain management physician in town where I live. And I was talking to him about it, saying, hey, it's designed for the busy clinician. It'll remember where you left off if you need to jump off the training and get back into clinic, and it cuts to the chase, and it avoids, you know, terminable like 5 minutes of the whole program just watching swirly graphics and elevator music to introduce each topic. That it's crisp and cuts to the chase, and it was a great note of thanks that we made it with the busy clinician in mind. So that may possibly be our first compliment about the sight unseen about our module. So, okay. And Articulate is the platform, that's the name of the program that our contractors were using?
so yeah, Articulate's the software that actually creates the slides and the, you know, graphics and all that, puts it all together in a video format.
Yeah. Any feedback from them about how we were shoveling all this material their way? Did they seem like they were taking it in their stride? Any general sense of how they were feeling about it all?
No, I think their term is a build ready, and they felt that when we started the contract, and again, it was, you know, it was well late in the game. They were able to take what we had and produce what Jason and I believe is a good representation. Certainly, far better graphics and interactivity. I mean, we gave you a brief snippet of it back in our meeting in November. But I think given the amount of content that was there and the complexity of the material to speak to a broad audience, I mean, I think they felt that what we did hand them was good. Now, could it be better? Sure, but
right. But they felt it was in their wheelhouse just fine. Huh?
Yeah, they were able to, you know, it was a pretty aggressive timeline there from
Yeah.
late fall into the end of the year. And I think if it weren't for some medical issues and one of their staff members, we would have been done. So
okay.
Yeah.
And you mentioned, was it the Oregon Medical Board hasn't quite yet given its
a medical associations act. So they're the ones that we apply to 2 associations for credentialing of this CME. One is the Medical Association,
okay,
and the Nursing Association. The pharmacy board, we also apply to the pharmacy board. They have their own approval, and application process. So.
And there's any specific points of concerns that they haven't approved it yet, or it's just they haven't gotten around to it yet, or they haven't seen it yet?
So the holidays for the medical association, they have to have physician reviewers go through, take a look at all. It's a complex application, and
okay.
Then to give and then the nursing association is the same thing, multiple pages and lots of specific details to meet the standard. And then they've had the Providence strike that they've been dealing with too.
Okay, so the process hasn't finished yet. Okay.
Yeah. So.
Yeah. All right. Okay. Anybody else have anything to comment? Well, I guess I'd like to just address the members of the public. It looks like we do have some public comment later. Mark, how many people do we have scheduled for this second public comment?
We had 2 individuals signed up to provide public testimony, and they, I'd follow up with an email and say, hey, would you like to, present the first section or the second? I did not hear back on the email, but I do have their contact information that they give us when they sign up. They give us their name and then a phone number, so that we can see it on the participant list.
Okay.
I still do not see them signed in at this point.
Okay. And then, yeah, because I'm just trying to, if there's a legitimate way of some of the folks that missed the earlier public comment section, at least from my end, unless there's some rule I don't know about, I'd be happy to have them try and sign in for the second, assuming there's no major rules of engagement there that would prevent that.
No, there's no, and they're allotted 5 minutes of total time. And so we've got plenty of time in that second session for both individuals to up to the 5-minute timeline.
Okay. So members of the public are within earshot of what we're saying. Just try and hang in there because there is that second public comment section coming up. Okay. Let's see.
You want to put the agenda up, Jack, or?
No, I've got the agenda here. So,
okay.
Yeah. So is there any of the commissioners that, have we all seen that introduction, or were some of the commissioners not here that day? I'm just curious, when do we get our first behind the scenes look, or before it's fully released? When do we get a chance to run through it?
I'll send that link out to people. As I was waiting to hear, they had some final edits to do yesterday.
Okay.
There was some renumbering of the navigation on the left side of the module, and then there was a case study that we added that was kind of not in the right order sequentially. It came in between pain psychology and the physical therapy. It should have been after osteopathic manipulative medicine, and then before the emerging frontiers piece, as a kind of as a review of the multidisciplinary approaches.
Oh, okay.
Example case study to say help people walk through that, and it's a very simple.
Oh, okay. Like with an example patient, you mean like a?
Yeah. And it's very brief. It's like maybe less than a minute. So.
Yeah. So when we have that link, commissioners are reviewing it. They'll probably have some kind of a opinion there. They should start sending comments to you. Well, certainly, obviously, we'll have agenda items in upcoming meetings. What kind of process did you have in mind for commissioner feedback once we get that link?
Yeah, please email Jason or myself, me preferably, and then I can, if you can CC Jason, great. If you don't have his email address, I'll loop him in on it. We'll want to hear feedback on, it was really hard for me to get in and signed in and into the catalog, and the kind of the logistics of getting signed into the course. And then I think the course itself is very straightforward, and then it'll be the back end taking the post test and then the completing the course evaluation, which is 10 questions, and then generating that certificate. And there are going to be 2 tracks. So you'll sign in, and anybody with an MD or a DO license credential will go through one track of the module. It'll be the same content, but they get a different certificate than everybody else. That's just based on the way the credentialing works through the medical association. That's for the joint providership agreement. MDs, DOs get one certificate, all of the license types get another. And so essentially it'll be the MDs and DOs will click on a link and go through that, and then set them up to get that certificate, and then everybody else will go through the other same course, but just a different kind of software path, if you will, to follow through. Does that make sense, Zachary?
Yeah.
And then as far as the overall feel and content and what you want to include next time, I think there'll be ideas that come up just based on taking the course and getting reacquainted with it, and will help inform our work going forward and for next fall. And because we'll have that turnaround for the next year, be working on it again in 2026.
So we needed specific permission from the pharmacy, the medical, and the nursing. Was there anybody else that needed an approval? Okay.
Yeah.
Behavioral health, nothing like that. Okay.
No.
Right.
Yeah.
All right. Well, it's 9:55. Let's go ahead and take a 10-minute break. I'll be back here at 10:06, and then we'll. Any thoughts come up about earlier agenda items? If not, we'll move on. Okay. Well, welcome back, everybody. The next item on the agenda is there's 3 things: representing the concerns report, the website content update, and the bylaws revision. I think just go ahead and rearrange that order a little bit because of this, our action item of how we'd like to proceed. And there was mention of how do we keep a list of how patients can connect with pain providing providers. The website project looks to be a little bit of a deeper dive. For example, I just found a link from our website to a Find a Doctor searchable web page from Boston Scientific that immediately asks you to filter by therapy, spinal cord stimulation, or Vertiflex trademark procedure. And those are your 2 options. And you can download a discussion guide where you explain your pain in detail. Let me just see if that's a commissioner here. Excuse me. And then make sure to ask would a non-opioid treatment such as a spinal cord stimulator, the Vertiflex procedure, or radio frequency, like ask your doctor. So somehow on our website, there's a bit of an advert for some of these procedures. So anyways, I just thought I'd let you guys know if we're digging around on the website, there's some things that initially look promising, but then as we dig deeper, have some obvious conflict of interest problems. So about the website, has anybody had a chance to click through to the point where they felt like they had an opinion? I'm seeing one nod. Floor is open. Is that Michelle? Were you nodding? Please.
I have been kind of searching around, and I have some notes that I was going to send to Mark also. So I'm doing my research.
Okay. I did find there is a couple places you can search for a federally qualified health center. And these often have good pain management programs. So you can type in your zip code and look. And then the American Chronic Pain Association has a quarterly chronicle. Looks like there's a free magazine that you can click through back issues as a PDF. So I encourage commissioners to read through a little bit about that. It looks like there's some articles written by pain psychologists, and some other specialists, and some patient stories as well. There's quite a patient-centered magazine, but that's all I know about it is what I found this morning.
Zachary?
Please, yeah, there's some idea that we actually need to thin out our website. Is it?
So yeah, I included in the packet the two. So on the left nav of the OPMC webpage, there's the health professionals side, and then there's the section for patients and families. And so we need to go through each of those and say, hey, let's get rid of this, clean this up, add this. And so there's the whole paring down of the website that OHA is requiring all departments to do. And there's getting the relevant content that the commission wants on its website, which we haven't done in years. I mean, even before I started, we hadn't even gone through that. So this is a good opportunity for us to go through and update. And then as far as adding content that, say, hey, oh, here's a list of providers, or, as long as that's something that is, I think, maintained by another resource where it's not OHA staff like myself doing that to have to update that on a regular basis, that's fine. But I think we've run into problems in the past trying to keep a list of non-farm pain programs on the website, because they kind of come and go, and it's hard for, as you can see, for staff to kind of keep this updated as it is. So, but if you pass through to an FHQ, QC website, then that keeps that list or something. That's fine.
It's interesting, Mark, you bring this up as someone, so everyone knows I'm on the board of the Oregon Primary Care Association and know our members pretty well. I would say that not a single FQHC would probably want that on there, because the patients we end up getting are patients that are often medical refugees that cannot get established elsewhere, or they have comorbidities where, we go into there wanting to support them, but really none of us would ever advertise that as a standalone. It really is for, the patients that, have a difficult time on OHP accessing care or Medicare. And so us providing that core safety network, absolutely the work of pain and resiliency is part of it. But just from a standalone perspective for someone from private insurance coming in, it's not really the model that we sort of are built for. We have very low barrier of access to behavioral health and dental services. We really create that wraparound service, but that's typically for patients that are going to benefit more from it, or that it's kind of. So anyway, I just would be hesitant unless they specifically stand up and reach out to you and say, yes, we want this to be known. It's more, we've had a legacy of overprescribing for long-term opioids for years, and it has fallen disproportionately on FQHCs at times. So we just ask that we engage with the center before we list them.
Right. Yeah, and then, like I say, there's this problematic on pain.com where it's a bit of a thinly veiled advert. So we need to.
Yeah, because what we perceive as a center of excellence for pain care is going to be different than what a patient would see, and the expectations can be often in conflict.
Yeah. I'm just looking through. Mark, was there some specific guidance about what's the ideal size for a web page from the OHA is looking at? Any parameter, number of links?
There isn't specifics around that. I think less is more kind of a thing, perspective in general. And if there's stuff that's, and this speaks to what Andrew was saying, is that, just stuff that is, we can defend in terms of federal policy or other types of things. It's not too far afield in terms of evidence base, and or is a source that is collaborating with us and willing to do that. It's just not be linked to them kind of silently, and then we're setting up patients and providers for more problems. I think down the road, I think we want to avoid that.
Yeah.
Yeah.
I found where the link for the FQHCs and things, it's under the patient self-care resources PDF. That opens a PDF with a lot of blue hot buttons to links. It's got American Academy of Pain videos, stuff about central sensitization. It's pretty dense.
Zach, do you want me to share each of those pages and run through?
Well,
What do you
sure,
want?
maybe just pull up that one as just, maybe just to take it as the one example. Oh, Michelle, sorry, I see your X there. Yeah, was that?
I just had a question of like when we are paring things down and doing like less is more, like is there like what is the standard of care like specifically for like the patient facing part of it? Like what are the things that we are looking to have and not have? Like we haven't really kind of gone through,
Yeah.
like this is not good or this is good. And like, how are we deciding what those resources are and where we do want to be directed to?
Yeah, I think that's a tough one because it's what is the commission's role and what's their, purview in terms of, and there's all of what we know as independent practitioners and all the things of living in this specialized field that we know. And so, yeah, I mean, how do you make a general statement about, this is what the commission recommends in terms of multidisciplinary care being the gold standard. These are some of the national resources that you can point towards that then, or these are some of the programs in Oregon, and to what extent can we add those or not? And I think that would be a good discussion for the commission to have. And then we have to true that up with what OHA can support.
Right. I mean, some of the links look extremely old. There's this one about 10-week classes offered in Albany, Corvallis, and Sweet Home, and it looks like a very old early 21st century graphics with an LCSW, but there's an email, but there's no web page for it. And I think even in the conferences and events section for healthcare professionals, there are no items to show. So I think pruning out some of the dead wood would be a good idea. But this, obviously overlaps with the options like we did with the opiate prescribing guidelines for the commissioners to have other action items that they want to discuss and introduce. And obviously the website can be a powerful tool for that. Patient information. Also, I think this idea that, we're trying to write a very broad module. I think items that we felt like were missing in the module, going into detail, going into the research, like Terry was suggesting, that the web page may be a good opportunity for that. The deeper dive section, following up on issues from the module. I mean, off the top of my head, for the Oregon Pain Management Commission, a place that's obviously got some of our publications, place about pain science, some information about self-care, like some mindfulness exercises, links to anything like OHP coverage. I mean, I think there's some basic stuff that we can flesh out, pretty common sense stuff we can flesh out pretty easily. Anybody find anything that they really disagree with that, like I found, like the thinly veiled advert? Any other problematic web pages anybody's found?
I found a link that doesn't work. Under the healthcare professionals, medications and prescribing, the CDC med calculator, that link says that the page has been removed, and then it takes you to an overdose prevention information page, but doesn't have the calculator.
Okay. Yeah, I see that.
Might be a good resource to have working on our page.
Looks like there's the next link below that, at least brings you up to a page that looks like it might work. The Oregon Pain Guidance Conversion Calculator. But I don't know if it's there. I don't know if it's functional, if it's accurate. Um, if prescriptions in somebody's wheelhouse and they have a minute, maybe to double check, see if that is actually a reasonable page. Yeah, I imagine some of the opioid prescribing continuing ed links are probably out of date.
Yeah.
Scope, pain. Okay, well, let's move on from that. If some issue comes up as we're going and oh, Michelle, did you have another comment? Sorry. Excuse me.
I just have a quick question. So, in our standard of care, are we looking for more resources that are organ facing, or do we care, like, say for example, when we go to, like the crisis hotline, are we doing that as a national hotline, or do we want like more of a Lines for Life hotline on there that's more organ based? Do we have a kind of standard of care for that? Do we want to
Yeah, I
pick
think
one or the other?
the statewide crisis line is a great resource to have on there, because they will have relevant, links to community-based services. So that's going to be, far better than a national one, I think. And a national one's great too, but I'd rather have. But then if you're getting into county level data, the Washington County Crisis Line or the Portland Metro Crisis Line, I guess those could be added too, but they're not going to have them throughout the state. Obviously, you're not going to,
Yeah.
So
Yeah, just out of curiosity of like, are we trying to go more Oregon, or are we looking at more national, depending on what resource it is?
I would say we'll go Oregon as far as we can be equitable and avoiding conflicts of interest.
Okay.
Stuff. So, so if there's somebody here that's a part of the commission that's promoting their program, then that's a different thing, right? So,
Oh, absolutely.
right. And it's stating the obvious, but you're wanting to get to more generalized information that is vetted and, like the National Pain Strategy or, the Health and Human Services Pain Task Force document, the federal document, those kinds of things. And if we have stuff like that the commission has done, the CDC endorsement, updating its marijuana statement, any of that kind of stuff would be, certainly appropriate resources that are in alignment with kind of more of an OHA facing resource and support, right? Something the OHA can back up.
I mean, does the OHA have is this the sort of place people will go if they're in a crisis looking for information from the webpage? I mean,
and I wouldn't be the
pretty
first
far
point of
down.
contact, but you never know who's looking at it or who's trying to find information, and it might
it's true.
save a life. So
yeah. Hopefully if we had, more urgent action items like that, for people, that eventually the search engines will pick that up in our website. So if somebody's just Googling that would be one place they could get that information. I'd imagine it takes some time once you update your website. Okay, well, let's, if something else comes up, please let me know in the chat, but we'll move on to the next section, the Representing Concerns report. Mark gave us most of the one we did from last year. The Appendix A wasn't with the package, but Appendix A were the commissioners at the time who wrote their own personal note about treatment of pain. It is on the website's version of the report, but I just don't, unless I missed it, that Appendix A is missing from the extracted PDF that came with the
yeah, I apologize.
no worries. It's just, but it is there if folk want to read it.
Well, I had intended just to remove the commissioner bios, and I accidentally anything else. So yeah.
I'm just curious. Let's see. Oh, okay. Jason's putting the full report link in the chat. Were there any commissioners who weren't at that meeting where we introduced this? I'm just curious. Were all of us here the day that that report got released? Seeing everybody kind of nod here. Okay. Oh, and I'm sorry, it's I'm learning to pronounce your name. Shavala, is that right?
It's Havala. The C is silent.
It's C, sorry, Havala.
That's okay.
I will endeavor to get it right. Thank you. Havala. Okay. So this actually overlaps, intersects with our bylaws mission, because I thought that this was part of the commission's work representing the concerns to generate a report like this. But actually, to my reading of the bylaws, it's not actually in the bylaws that we need to make that report, unless I misread something. The bylaws really talk about the mission being generating the module, and then needing to pay particular attention to some underserved communities. So this report's been out for a while. Does anybody have any comments, concerns, things that they liked about it? I myself thought it was extremely well done. It's very thorough, the way that they were able to track over so many meetings, the members of the public's comments. And I appreciated the chance for the commissioners to write their own piece there in the Appendix A.
And Zach, this is a kind of a refresh on this. This was a report that is required by statute and was submitted after several years of not submitting one to the legislature and the governor. And so there was some historical data information that was included in this, that going forward, the timeline will be July 1 through June 30th. That will be the year in which we will report on. So we're in the midst of next year's report, or this year's report, going this fall. So we'll wrap things up in terms of information collection at the end of June, and then we will move forward into the fall meetings and review a draft and approve and send that to the legislature and the governor. And so what do you want to include?
Actually, Mark, I think we should double check that. I think they want the report delivered by June 30th. I'll double check that with our government relations.
Oh, okay. That would be good to know then. Okay.
Yeah, we'll get that. Yeah, so I think we need to be starting working on it and developing our approach.
And that means the May meeting would be the only time for us to work on this as a commission?
Yeah, so it'd be great to get some instruction from you all. Do we want to do a survey? We talked about doing a survey. Do you want to all just do statements again? Should there be any, review of the statements that come in to meld them into a cohesive message? We had some diverse opinions as is expected from a group such as yourself, but those would be some good things for us to get advice so we can start pulling that together.
Could you unpack a little bit about what you mean by a survey?
So we could do a survey that asks specific questions of you all as commissioners as to what you hear from your patients. We could do a survey of the public members on our listserv and invite them to offer their perspectives. We could ask certain questions, to kind of structure it around some key themes. And, that would be a way to do it that's it's a little easier to answer a survey than please send us a message. On the other hand, it provides structure, but it's also less flexible. So it would be helpful to know what you all would prefer.
But so it sounds like we should really make some headway on planning this, because this is the only meeting we have before the May meeting, and then the report's due in June.
Yeah, I'm realizing that too. I think I'm used to working with Herc where we have more frequent meetings, but yeah, let's do get some approaches, and we can send stuff out for feedback in between meetings,
Okay.
and
Yeah.
discuss that with Zach and Russell.
I mean, I think the overall summarizing public testimony is a good idea. I'm all for that. I think a survey is a good idea, but also to allow, you know, some limited number of words like we did last time, just the personal touch from each commissioner, just because there's probably some nuance that as useful as a survey might be good to maybe have both if that's possible. Britta, I see you got your hand up.
I really like the idea of if it's not too much work, just sending out a survey to the listserv of the public who have testified, or however that works. As not everyone's going to be able to sign up to come to a meeting and share, but I think that we could get some valuable information that would be useful to sift through.
Yeah, I like that idea a lot. Actually, it's another opportunity for the public to contribute to the process. Is that a big lift?
No, we can certainly create a list of questions and then put that into SurveyMonkey and have a link to send out to the listserv, and then individuals can respond, you know, between an opening date of that survey and the deadline, and just put a deadline on it so that we close the survey and then compile the information and put it into a report or a draft.
Okay. Scott, see your hand up.
Was there any feedback from the legislature or the governor about what we presented?
Great question.
There was no ripples.
Yeah.
I have not
heard anything. Yeah.
Who was it sent to?
I believe it was sent to the governor and the director of the health authority and the legislature, or sometimes it's just the committee chairs that get them. I can confirm that.
Okay, like all committee chairs or just healthcare related committees?
Probably just the healthcare committee chairs, but I'll confirm that with our rep and let you know if I hear back from her during the meeting.
Okay. And in that process, there's no established process of receiving feedback. So if I'm a representative on a healthcare committee and I receive this report, you know, if I had something to say, what would that look like?
They know how to get our attention. Yeah.
I'm just checking. Yeah. Sorry.
Yeah. They just reach out to our government relations team and we jump. Yeah.
Okay. Yeah. And so they've had it for some months now and nobody said anything.
Correct. And usually if we were going to get feedback, we would have gotten it by now.
Okay. You know, is it like, sorry to use a facetious example, like restaurants, if there's like one bad example, you hear more about it than if there's a restaurant doing well, like we're more likely to get complaints than positive feedback, or it could be anything. Okay. Yeah.
Yeah. And I guess the other thing I'd say is, even if we don't get feedback, even if the legislature, you know, they're getting a lot of these reports. I don't know how many of them they read, probably depends on their interest level in this topic among the many things that they address. But if they get constituents questions,
yeah,
is a resource for them in understanding the views of the commission. And, you know, if a bill is introduced, hopefully this gives them perspective on, you know, what they want to do about that bill based on the needs of our patients in Oregon.
And that begs the question, and what's the appropriate size for one of these reports? Like how many pages, given that they're already receiving a lot?
Well, the way the statute is written, it can be whatever size it wants, but we have to do a 2-page summary.
Okay.
And they're sent a 2-page summary with a link to the full report. So, you know, and I think less is more, of course, but we want to hit the major themes in that 2-page summary because that's our chance to get our best chance to get their attention.
Okay, and that 2-page summary was in the report, or
no? I think that was just distributed to them.
Okay.
Honestly, don't remember exactly.
Yeah, if we could get a chance to have a look at that, just so we can,
Okay, I can dig that up.
that'd be a great, especially, yeah, if you could send that to commissioners. And any other comments from commissioners about it? So am I right in thinking that the next report probably won't be quite as long because it'll cover a less extensive time period with fewer testimonials? Like today, there was, there may or may not be any, for example.
Correct.
So, okay.
I'm sorry, you wanted the deadline for the next legislative report confirmed, and then who received it, and a copy of the 2-page summary, right?
Thank you. Oh, Jessica, there's a note from somebody. Maybe you could reach out to them. They're having some technical problem there.
Regarding the chat window.
I guess so. Yeah. Okay, well, the next section is the bylaws revision. And I must admit, I hadn't looked at the bylaws for some years. The first thing that I noticed, was that the bylaws seem to be rather pain management module heavy without some of these other obligations from statute listed. So, Mark, was your intention that we maybe go do a deep dive today and take some votes and make some changes?
Well, I think today, this is probably more of a deep dive, bring up some issues. There's some things that you would like to draft and or include, for approval in May. There's no deadline that we have to do this by this meeting, but that was something that in the Senate Bill 607 report that we submitted, which is along the same lines of that representing concerns report, we spoke to taking a look at the bylaws, and there was some public comment and testimony about that the bylaws hadn't been updated. And I think the last update we did was in 2020 or 2019 that then became effective 2020. So it's been some time, and there's probably some things that you can address, and there's some others that are just kind of pretty standard based on the statute that there's not much else you can do about.
Right.
Yeah, staffing and that kind of thing. So, number of members on the commission.
But it looks like then it'll change a little bit because the composition of the commission's been changed by the OHA to include more public members.
So we can take a look at that and see.
Article 3, page 32 of the packet, page 2 of the bylaws.
Okay, I'm going to go to the packet here. And hopefully I got the page numbering right. So 32, is that what you were on?
Yeah.
Okay. Can you see that?
Yeah.
Okay, cool.
Composition of the commission. Yeah. So I imagine we don't need to vote on something we were being asked to do anyways by the Oregon Health Authority to change the composition. So that's a de facto change. And I'd totally forgotten that 2 of our members are supposed to be from a legislative commission with jurisdiction over human services issues appointed by the President of the Senate and one appointed by the Speaker of the House of Representatives. Have we ever had any of that category of member attend meetings?
We have historically. There was a senator prior to my coming on board that was Jackie Winters that was participating in the Pain Commission. And then we had a representative, Scouten, that was participating up through about the start of the pandemic. And then other things became more, obviously a priority for the rep. And then she left the legislature. So, but since then, we've reached out to our government relations team, and I know that there was an individual that was working on trying to stimulate interest, find out if there's interest, but we haven't heard anything. Unless Jason, you've heard anything. I haven't.
Oh, sorry, Jason, you're on mute, I think.
Sorry, everyone. Yeah, I heard there were discussions, but I don't know that anybody has been selected at this point.
Because that's interesting. I mean, having actual representatives on the commission, I mean, here we are wondering where our report's going to go to, but to actually have, members at that level who are just here anyways, and then going and talking to their colleagues at the Senate and the House of Representatives. I mean, that's also seeming like almost more potent than a 2-page report. I guess the issue is there's probably nothing we can do to make it attractive or interesting for such members to come.
Well, I do think that we are compelled to generate that report, and it needs to go to all parties involved per what our bylaws are, right? And that gets disseminated across multiple individuals at the legislative level, which includes the chair of the health committee, probably the entirety of the health committee, and some select people. So we may be able to attract a representative of some level to attend the meetings, but that doesn't alleviate the burden of still generating the report, because they probably, in working with legislators, they're probably not going to go have a lot of conversations with their colleagues about our meetings unless there's something actionable, new, interesting, or a proposal. And so that's where the larger report comes from.
Sure. So we should put the need to make that report in our, like I say, it looks like there's a little bit of a difference between our bylaws and the statute, because the bylaws really only talk about making the module, not about anything else that we do.
Yeah, to be clear, the report is not specifically mentioned in the statute, but we should, since we committed to do that, we should update the bylaws to include that.
Okay. So the report is just a self-generated action item from the commission?
Well, you all requested, there is a duty in statute to represent the concerns of patients to the legislature. There's just not a specific deliverable.
Okay.
And so in response to concerns from you all, I think at the prompting of some of our testimony.
So that's how we've chosen to interpret the need to represent.
Exactly. And in the past, the interpretation was different. It was, be there when called upon. And now we've decided to be more proactive.
Okay. Yeah, so that would be good to flesh out our mission statement in Article 2, Section 2.
I believe there was some desire from some of the people who wrote in for us to look at the public testimony. I believe we're handling that a little different now than I think there was talk about a forum in the past. And I'm guessing we should update that to just represent what we're doing by taking testimony with each topic.
Okay, which section of the bylaws are you in for that?
I suspect it's meetings.
Meetings. Quorum. Members of the public. Members of the public are invited to attend all scheduled meetings. Public comment periods will be established based on the agenda for each meeting.
Maybe it's fine.
And that's left us that flexibility like we've been doing. I think we were, difficult to please everybody about where to put the public comment in the meeting, and we've gone to break open instead of just one monolithic public comment section. We'll have topic specific sections.
Yeah, what happened historically was they did have some language in the bylaws that called out a specific public comment forum 3 times per year. And
That's
so
right.
that became difficult to achieve, I think, and became confusing for the public because they didn't understand the difference between a forum and public comment testimony. So they changed that language to be more succinct to just per the agenda.
Okay. What did a forum look like?
It was just a simple 20-minute public comment period. That's all it was. It really wasn't. I don't know what the initial intent of describing it as a forum was, other than perhaps it was. I know they did early on in the commission work. This is early 2010s in that area. I know they did more public kind of around the state where they'd have forums where they'd have, several commissioners would go out and then they'd have a town hall type of setting meeting, and there would be some feedback that was given to the commission. So I don't know if it was kind of born out of that or, but I think when I came on, it was difficult to kind of manage that and it comply with what they had in their bylaws, so they changed it to this. And then there was discussion about, tying it kind of like what HERC does, tie it to an agenda item so that you get more specific feedback around a topic that you're discussing,
right?
Instead of just a general kind of, obviously, individuals that sign up, members of the public, can say whatever they want, but it's nice to have specific feedback if you're requesting that or seeking that.
Yeah, I think we got complaints that, by the time the public forum happened, all the decisions had been made. And so we wanted to offer a chance to offer feedback on the specific proposals. But I think some of the patients also want to just talk about their experience and be heard by the commission. And so there's kind of two things. And I just think we've changed how we're meeting those goals. And so we should update this to reflect that.
And well, okay, yeah, then if we're tidying up language, section D of the meeting section, Article 4, the minutes of the meeting shall be taken and distributed. And I think what we're doing now is we've got an automated transcription service. Is that correct?
And we're posting a video.
You're posting a recording of the meeting to the meetings page. So that suffices for minutes now.
Okay.
Yeah.
I thought I saw a warning about transcription at the beginning of the meeting.
Oh, yeah. And so anybody participating in a Zoom meeting can turn on transcription.
Oh, that's just that. Okay. Yeah. I mean, the point about the minutes is not to record everything. It makes searching for what happened in a meeting difficult if all we have is a video, because I don't think we can, if somebody wanted to search where in the meeting did we talk about the bylaws, they'd have to fast forward. I've always been just a little bit of concern with that. Is it possible we could get it transcribed so it's a searchable text?
We get that automated transcription. It is buggy, but it is better than nothing. So we can look into that, or we could also do a brief minutes that just has like the timestamp where each topic started and then any votes or something like that. What was happening, it was taking a lot of time.
The reason to have minutes is to be able to search through past meetings to look at, where business was occurring. And if we just have, hours and hours, 2, 3, 4 meetings, it's 20 hours of video to search for something in particular. This seems a little bit unwieldy. How does the HERC do that currently?
The HERC does have minutes. The HERC has a lot more votes and action items and a lot of detailed proposals. So we've continued to do minutes. But Mark and I can look for a way to address the concerns you're having. Are there others who want to chime in as we develop a proposal for that? Looks like Michelle might.
Yeah.
Maybe I missed something. Was this the first meeting that we haven't had minutes and approvals? Or have we not been having minutes and approvals
It's been a while.
for minutes in past meetings and I'm just realizing it now.
There was a law that passed, I believe it was a year or so ago, that made that change. I don't remember what the exact date, but it's been several meetings now.
Okay.
It's been quite a while.
And then we had the recording failed for one meeting, and so we had to do minutes anyway. So
yeah, one of my professors said, minutes aren't seconds, to that granular level of
right.
So
we could get like a one-page summary of the meeting that has any key votes, and then where to look on the video and a link to the video. Would that address the concerns?
Yeah, we could give that a shot. It depends on, how important keeping a record is of what we're doing. Not having minutes and just having the raw 100% of the data. So, I mean, it sounds like that what you're suggesting is at least doable. And so let's try that, and then I'll take a look and see what that actually looks like. Certainly for me, like if I'm trying to find, it was easier if I needed to find something in a meeting. Wanted to look back at the minutes, like if we have a member of public that said, hey, this happened, and that was a difficulty for me actually with the feedback from the public is there wasn't a lot of detail for me to understand the nature of their argument. They would say, there's this problem and there's that problem, but there's no idea of the time that was happening or what was the nature of the problem. There was just, I don't like the commissioner selection process, but then there was no, cogent argument for me to understand exactly, what the problem was to see if we could fix it. So in the future, if we come across that, having a little bit better searchable database might be helpful.
So especially around the public comments.
Well, especially, yeah, around public comments and about the way that we're, I was struck by how some members of the public said, they never talk about this, whatever the topic was. And I remember quite vibrant conversations discussing such issues, like absolutely separating opiate, use disorder from legitimate uses. And it was strange for me sometimes reading criticism where I couldn't actually track that what they were talking about was actually happening in the meetings. So it was helpful for me to formulate my own rebuttal to some of those criticisms by looking back at the minutes. So,
okay, Mark, let's talk about ways to address that concern. I know it was very time consuming for Mark to create those minutes, but
yeah, and we've got to find something that's going to work. Absolutely, yeah, no, I totally understand. And then the next section about subcommittees. It seems like our subcommittee work we've just been doing as a group commission, for example, with our CDC opiate prescribing guidelines. I know there's talk about some low-hanging fruit about revising our cannabis opinion statement. It seems like we're doing a lot of that work as a group together, but I don't know if we need to necessarily change any of the language around subcommittees. Does anybody have an opinion about that?
I would just say it's good to have that language there in case you ever need. But
oh, that's what I'm saying. Yeah, no need to change was my point. Yeah. And then yeah, it's interesting, duties and responsibilities of commission members. I guess when we were all in person, it's a little bit more difficult to duck out and deal with a problem in the clinic. That's a phenomenon of Zoom and our post-pandemic world. So at some point, it mentions that 2 consecutive absences, and that, if I understood that correctly, that just meant back to back.
Correct.
Specifically as consecutive. Okay.
Consecutive, non-excused. So if you send me an email and say, hey, I can't make the meeting, or you call me, then that's an excused absence. And certainly we want to keep commissioners engaged and understand that they have professional clinical obligations and things change in their lives. So,
okay,
if a commissioner's not regularly showing up to meetings, I usually reach out to them and say, "Hey, how are things going? And are you still
Sure.
interested in participating?" That kind of thing. So,
But where does it say excused absences in our bylaws? I don't know if I found that part.
I don't think it says that. That's just kind of how I was told that was the method.
Says two
Okay.
consecutive absences may cause the commission to consider a member incapable of performing the duties and may result in, so there's room for judgment there.
I see. Yeah. Okay. So okay to leave that language as is? Any comments from anybody?
And I'll just say the major issue for us is, and for you all, is that it's not a meeting unless there are 9 members. It is not a public meeting because there's not a quorum. And so that's why, if somebody's missing 3 or 4 meetings in a row and somebody else is missing, 3 other people are missing 1 or 2, and
Yeah.
you can result. We had a couple, not recently, but during the pandemic, and I think before the pandemic, a couple cases where we just didn't have enough people there to conduct business, and that's why we want to make sure those who are involved are actually involved.
So I imagine we'll be taking motions and voting on motions more, the more action items come up about the website, certainly the next iteration of the module. So in the next few meetings, I imagine the need for a quorum will increase. We'd probably need to have a motion to approve if there's, like you suggested, Jason, the time-stamped summary of the meeting. We'd probably need to have a motion to approve that.
As the minutes, yeah. Mhm.
As the minutes, okay. So yeah, so pretty soon, needing to make quorum is going to become a bit more important. We're in a little bit of a motion dead zone at the moment, not so much happening at that level. Okay, yeah, and it just digging even deeper about if people have ideas about the bylaws, it says adopting the bylaws shall become effective upon a majority vote of the commission at a duly convened meeting. Commission members must be given notice of such a vote at least 2 weeks prior to the meeting. So that sounds like a little bit longer warning than the meeting packet.
Right. So what we would do is we would, based on the feedback you all provide, we can send out a copy, post it publicly at least 2 weeks before the meeting, probably more than that. Ask for feedback. Hopefully everything is 90% plus ready before your next meeting.
Okay.
And then those changes can be voted on in May.
Okay. So with some of the language we suggested today, can you just present that at the next meeting, and then maybe we can vote on making those changes?
Mark, does that sound?
Is that doable? It just like in the mission section.
Yeah, that sounds
clarify. It should be in our bylaws. What we're doing is what we're doing. It seems a little overly focused on one element. I am curious about in that mission statement, take into the account the needs of Oregon tribal communities, communities of color, other groups who've been disproportionately affected by adverse social determinants of health, et cetera, et cetera. I mean, no doubt this is an important topic. I'm just interested that that's in the mission statement. Do we need to have a further action item in that language take into account as we do our work or as we develop the module? Does that need to be unpacked a little bit with some clearer language, or is that sufficient for such an important topic?
I mean, I think that with it being in the mission statement, the implication is to take that into account through all actions and interventions. So I think that's reasonable as written.
Yep. Just bringing it up because it's an important topic. So I would agree with what you say, Russell. But let's see. Have we been seeking out the assistance and cooperation of national associations in meeting objectives?
We have not really been, I mean, other than my own, research into what we did for the module in terms of resources, national resource, CDC resources and that kind of thing, but we don't have communication necessarily with.
Yeah.
I mean, the CDC is a national.
Oh, there you go.
National organization, and we did a deep dive and review into their protocols and recommendations, and so that, I mean, while it may not be direct interaction with their staffing, it is an interaction with their publications and their policy, and so I would say that falls under that category.
Okay. Yeah. I'm just trying to double check if there's something in our bylaws that we should be doing that we're not, but I'll take that point as well said. Anybody? Sorry, Michelle, was that an older hand up, or did I totally miss you? And then Britta.
Britta can go first.
Okay. Sorry, Michelle.
I just would be interested in hearing if anyone else feels like, so under section 3, principles and values, but the 1, 2, 3, 4, 5, 6 bullet down on page 32, view people in pain as members of our society and encourage them to be heard. I wonder if there's like more, how does that work? Is that sort of vague? Is there something we can do to be more specific about that? Or is it good that it's a little
it's
more
a little awkward? Yeah.
I mean, I think that we have a public comment section, and there was a forum previously that just didn't end up being functional, so it was transitioned. I mean, I think that that's in the spirit of trying to encourage patients to be heard about their pain experiences or their goals or their concerns. And there's quite a bit in the modules and the patient resources, at least historically. I assume they're still there, in how to advocate and have those conversations.
Yeah, I'd almost change the word view to validate or something. Validate people in pain as members of society and encourage them to be heard. But,
or acknowledge.
Yeah, something. Somehow that's striking me as awkward the way it's written. Okay. Michelle, was there something you wanted to add? I'm sorry, I was lost in the text here, and I don't think I saw your hand.
I had a question later on about the subcommittees, but continue on with this section.
Okay, yeah, no, I don't think there's anything else. We'll get some new language at the next meeting. I think Jason and Mark will work on that. Please, what was your idea about the subcommittees?
I just had a question of like updating the section about the subcommittees because of our new way that we have to conduct subcommittees in a public way. Is that reflected here? And can we update that languaging to make it easier for the commission to do work on a subcommittee in any way?
Good questions. Yeah, Mark, maybe you could revise us the rules about subcommittees. Is it lining up with our bylaws here?
Yeah, so anytime a group of more than, I think it's 3 and commission members engage in discussion, has to be public meeting. So we have to meet all the public meeting law requirements in terms of notification, and keeping minutes, recording, whatever, all that stuff needs to happen. Whereas I think in the past there was some wiggle room in the language and some changes that came about in public meeting law that allowed the subcommittees to operate and report back to the commission, and then have the public meeting and public input and comment at that meeting based on the input from the subcommittee. But that's no longer the case. So anytime you have a subcommittee or get together or email exchange, it's got to be public forum with more than 3 people.
So that was kind of my question of like, what is the point of having subcommittees if they have to be like, we haven't done subcommittees in a few meetings or in a while because of the public forum. I'm sticky on the whole thing and it doesn't make any sense to me.
Well, I think as Jason said, you keep the language there in case you need it. But
Yeah.
you try to conduct business within the 4 meetings that you have per year, and realize that if you're going to have a subcommittee, it's a bigger lift in terms of volunteer time and staff time and everything that goes into that. And so you have a choice. Either it's a public meeting with a few commission members, or it's the regularly scheduled meeting with everybody. So
Yeah, I can imagine, I'm just picking an example, if you were updating the medical marijuana statement and you wanted to assign 3 members with interest and expertise in that to work on that, but you wanted them to receive public testimony to inform their work, then you could appoint them as a subcommittee versus just having a group that works with Mark as staff, a staff advisory group, which would not occur in public and, would potentially get scrutiny that it wasn't happening in public. And so I think that's a choice whenever there's a group of members that are assigned to a task like that. Will it be better function as a staff advisory or as a public meeting and with a subcommittee that has actual votes and everything?
Because my reading of Article 7 doesn't actually mention that the subcommittees must follow public meeting rules.
Yeah, we can add a mention of that because that is in statute. We don't have a choice about it, but
yeah. So we should copy and paste into our bylaws. I mean, in future, Jason, Mark, like, what is our resources to host a 5th meeting a year, or if we ever did have a subcommittee on a topic?
Well, that's at your discretion.
We would have to get funding permission, or we've already got approval for that, or like, what would that process look like if
it would just be subject to our availability of staff? So we could do 1 or 2 of those, but if we're not going to do it every week, we'd have to.
Oh, okay, right.
Call. Yeah.
But any work that subcommittee did, because it's 3 people, would have to be. They couldn't have a private email chain saying, "Oh, I found this article, I found that article."
Exactly.
I see. Okay.
So we'd schedule a Zoom call. We'd announce it on the commission website. Anybody could come and attend. We wouldn't be required to have public testimony, but we probably would.
Yeah.
Those kinds of things.
Yeah, I purposely made because Gmail accounts are free, just an OPMC email account for all OPMC business. So, if we ever are, audited, or people want to see the work of the committee, I've got it all in one. You're not getting my wife's email about what do you want to do this weekend or something.
Right.
So just let commissioners know that that's an approach that I've taken. I think I'm ZC dot, it's something OPMC related Gmail. So, okay. So yeah, Mark, it seems like that's working okay with commissioners sending you information, agenda items, ideas of people to invite as guest speakers. My perception is that system seems to be working okay. Would you agree?
I would say so. I think, I try to bring everything I get to our leadership meetings with you and Russell, and discuss with Jason, and then we present, put those on the agenda. I know that Dr. Klein had one email a month ago or so that she was interested in discussing, and we need to put that on the leadership agenda. Certainly as other members of the commission have input. I know, Zachary, you had wanted to do that kind of a forum with some of the clinicians in the Eugene area, have kind of a speakers group that come and talk to the commission. So, but yeah, email me individually. That works great.
Okay. So we're really very ahead of schedule for the public comment section. What's that looking like, Mark? Do we have people in the pipeline here ready to go? Can we bring that forward?
We could if we had individuals signed in. And I'm seeing guest, I'm seeing Tom, I'm seeing Ann Cataldo,
Okay.
and I'm not seeing the two individuals that signed up or their phone number.
Okay.
So I guess unless there's somebody that signed in as guest that can put in something into the chat, or is signed in as the name Tom or Ann Cataldo, that is one of the two individuals that signed up to provide testimony, and they can alert me to the fact, then
Because the rule is they have to be ready to go, how long before the agenda item is officially posted?
well, 30 minutes prior to the agenda item needed to be
I see.
something. for the meeting.
Okay. Yeah, sorry, folks, this has never happened before that we're that far ahead of schedule that we have 20 minutes before we have basically invited people to come speak, and we don't know if we can easily bring that forward without prejudicing their chances. Well, Mark, I might as well add just a little bit of business. So when do we think we'll get confirmations for the new commissioners who have gotten through the selection process? What would be is that by the May meeting, or?
Oh, yes, and I think that there's been some change internally. I need to talk with Jason. I think I received an email from him on will be the appointing authority under the director now. But that should be within the next 2 or 3 weeks here.
Okay. Yeah.
Depending on how busy folks are, above chain of command for me.
Well, listen, I'm going to go ahead and call a 2-minute break because I need one. And well, that'll maybe give our guests a chance to update their chat. Share again.
The recording is resumed. And I got a direct message that someone did not sign up for testimony because January is a very painful month for them. So that's why one person hasn't signed up for testimony, but that doesn't account for the people who already signed up. So
I mean, did they mean they had signed up but just can't log in today because they're in too much pain? Is that
no? But they would have, but that January is a very painful month. So
understandable. It's freezing out there. Yeah. Okay.
Zachary, I just have an update. If we want to
Please.
give them just a minute or two. You had asked about the representing concerns report, and we're doing that, even though we wouldn't be required to do so, using a statute that requests that the 2-page summary, which I just forwarded to all you members of the commission, be forwarded to each member of the Legislative Assembly by email with instructions on how to obtain the full report and a link, if it's posted on the internet, which of course ours is. So each member of the Legislative Assemblies, Senate and House, would have received a copy of that document that I just emailed out today. And that's how we make our reports.
Thank you. Great. Yeah, that link does work. Okay. I mean, just because it's there, if people have their email, because Appendix A was not part of the packet, if any commissioners would just take a minute to find their name, do they feel like they were adequately, their comments were adequately represented? Looks like myself, Russell, Carolyn, Britta, Eve, Terrence, Christine, Scott. Maybe just review if you haven't already done so. I thought Andrew had written something.
Yeah, I think that very last bullet on the second page was the one that was a little challenging for us because there were some different perspectives around opioid medications. expressed, and so we just acknowledge that.
Okay. I could have sworn there was a note from Andrew. Andrew, did you write something for this? I could have sworn I saw your name somehow. Maybe you didn't. No, fair enough. Yeah, it looks like I tried to write something a little bit about my experience with the commission process that fair enough got edited to fit Appendix A, just relating to reports about my own experience with patients, what they're telling me about pain. So just fair enough. That's what happened. No big deal.
Oh yeah, we just edited that to
Yep.
focus in on the scope of
Focus
the
the-
report. So
Yep. No, that's fine. So yeah, I thought mine was pasted faithfully there. Okay. Okay, Mark, Jessica, so we've got no guests here meeting our electronic requirements here to sign in good time.
Unfortunately, I don't see anybody, Zachary,
Okay. Yeah.
that signed up for
The
the.
person just listed as guest didn't update further
Nice.
identifying. Okay.
Yeah.
Okay. So for members of the public, let's just review. They have a chance to sign up. Is it a week ahead of time?
When the packet goes out and the
Yeah.
listserv notification for the meeting goes out 7 days prior, they have until 48 hours prior to the meeting to complete the survey, to sign up for public testimony and or submit written testimony.
Okay. And then once the meeting starts, they have to be online 30 minutes
prior
before the posted agenda item. Okay.
Yeah.
So that automatically gives us this wiggle room like today where we're finishing ahead of time and we needed to start early. Okay. That's fair enough. Well, I guess if you're out there, I did my best to get you online today. Hopefully next time. So the next meeting, hopefully everybody can make it in person. It's great to meet in person. If you can't, there'll be this hybrid family squares kind of situation on a screen in the classroom. It's in the same location. Have we booked the same room?
Yeah, we booked the same. It'll be the Clackamas Community College
Okay.
Education Center in there, Wilsonville, and then I think it's room 112. I'll have to look at the contract, but I'll get that information. It should be on the website, and or if it's not updated, the specific room number, I'll get that updated when I have it. But yeah, so
Yeah, it's this Clackamas, the what is this, an ICS file for May 22nd. It's already got the Zoom link for people, but yeah, it just says Clackamas Community College in Wilsonville. Doesn't have the room number yet or anything. So
I'll get that update. I think I need to check with Jessica, and we were going back and forth with their contracting person there at CCE. So.
Yeah, it's a very nice facility, actually. The parking's very easy. It's near the 5. I'll be coming up from Eugene. So hopefully everybody can make it either in person or via Zoom. And members of the public are allowed to come in person, right?
Oh, sure. Yeah.
Yeah. So that would be, how does that work then for if we're ahead of schedule and we have a person scheduled to be in person to present and we're ahead of schedule, like how soon is that the same? They have to be there in person 30 minutes before the agenda item?
I think typically they have to sign in and then they not only sign into me, but that they would like to provide public testimony.
Yeah.
To be present there. Yeah.
But how does that work exactly? So if we have a guest who wants to provide public testimony in person at an in-person meeting, it's 48 hours before the meeting, and they need to actually be in the room by what's the cutoff point?
No, it would be if they were in person, they could show up the day of but we would, I think, state that they need to be there. Jason, correct me if I'm wrong, 30 minutes prior to the agenda item.
yeah,
It'd be the same. Yeah.
Yeah, so it'd be the same. Yeah.
Okay, great. Yeah, just again, if we're ahead of schedule next meeting, we don't want to cut anybody off, but we know if they're not there 30 minutes before the agenda item, then that's why we have the 30-minute cutoff point. So Okay, any other questions or comments? I appreciate it was a bit of a slog through a lot of bylaws and reports today. But I appreciate everybody's feedback. Any final comments or questions before we sign off?
I'd just like to add on the website editing. So if commissioners can send me any information that they would like to include, that would be great. And then what I'm hearing, Zach, is that there are broken links and other things that should not be there. We're okay to remove all of those as we see fit, and just go ahead and do that. Is that correct?
Yeah.
Okay.
And yeah, please do send Mark's interesting links, useful stuff for patients and for providers. So marvelous. Okay, hearing no further questions, seeing no further hands up or X's in the chat, I'll go ahead and close the meeting today at 11:22.